Welcome, everybody. I'm going to talk today about structural racism. And this is not my usual talk that I either give to the students or to anybody else. This is actually a combination of things. And it mostly derives from a talk that I gave to the NIH about a month ago, maybe 2 months ago, which was not that well received, I have to say. I was invited to talk about research and disparities, and the only reason I know it wasn't well received, although it got a lot of applause, was that I never got a thank you note afterwards. Usually when you do something like that, you go all the way to Washington and stay overnight so you can do rounds. But it was at the, I think they were more focused on research as I got to listen to the other speakers, and I think this was a little too political for them. But what I want to talk about is structural racism. And the reason I want to do this is because I think if we don't understand the things that are happening in government, and in the milieu in which those of us who've been struggling to fight health disparities, if you don't understand the milieu, it's really hard to kind of think about what the next moves are in our struggles. And so I want to start with this. This is one of those pins that I still have on my bulletin board from college. And this was an organization called Science for the People, and I started out as a research scientist, actually. And the interesting thing about this was it says, our purpose is to raise consciousness of how the sciences serve the ruling class interests, to demystify science and technology, to organize students and scientific workers to use their skills to support people's struggles. And I realize if you just take out the word science and you put in medicine, that's sort of what I've been spending my life doing. And it's what many of the people in this room are committed to as well. And I think that's why we are together. This is a slide you may have seen before. It shows the racial distribution of the population by age. Let me just say a word about research. A lot of what you're going to see here is research. It's the kind of research I've been doing, which doesn't mean that these are controlled clinical trials. It means that you go to the literature and you try to oftentimes just express things in ways that are different and that help to show lessons that you might not see otherwise. So if you take the census data and you sort of map it like this, and you just kind of like look at the population at every 5-year interval, which is what I did after the 2010 census came out, what you find out is that the population of America whitens with age. And the reason it whitens with age, that's the blue line at the top, the reason it whitens with age is because people of color are dying prematurely. And if you sort of want to have one slide that represents health disparities, this would be it. And it's basically the premature death of people of color in this society so that the population whitens with age. The two vertical lines are important, but especially the one on the right. And the one on the right shows that at age 65, which is when people go on Medicare, at age 65, you're already at a point where 82% of the population is white. And remember, it starts at like 67%. So that's where Medicare kicks in, and we'll come back to why that's an important sort of date in a minute. But this is what it looks like in New York State. And if you look at New York State, we have exactly the same sort of distribution with the whitening of the population. We start out at 48% in New York State, and it still goes up to 82% in the latter years. So you can also look at this in a survival curve. I used to use these when I did experiments with mice, and this is now with people. But you could say that if you look at this, what this shows is the percentage of people that survive and for how long they survive. And so you can see that actually Hispanic females have the longest survival. But if you look at the bottom light blue line, I guess you can see that, yeah, those are non-Hispanic black males. And black males always fare the worst in any of the statistics around disparities and premature death. So the story about this is that health outcomes in this country get better. They're getting better in almost anything you look at, but disparities aren't. And you can do this for almost anything that you can find data on year by race. So here's life expectancy at birth. You can see it's going up for everybody, but there's still huge disparities. If you look at age-adjusted death rates from heart disease, they're going down for everybody, which is a good thing, but we still have huge disparities. You can even do this kind of testing, this kind of graph for any kind of test. So these are colorectal tests and colonoscopy, so that, we're doing better, getting more and more people tested, but the disparities are still there. And that's basically the story of health disparities. Things keep getting better. This one's particularly interesting or sad, and this is basically the change in the 5-year relative survival. So if you look at this, you can see that between 1975, which is the light blue, and 2006, which is the darker blue, that basically there's been an increase in overall survival for whites of about 17 years, and for blacks of about 17 years. And the disparity of 7 years in survival basically has remained exactly the same over this period of time. And this is data that's captured on all cancers. So, no matter what you look at, you find the same story, basically. And even if you look at the uninsured rates, and you do this through the time when the ACA was impacted and so impacting the rate of uninsurance, you can see that everybody was getting more and more insured, but the disparities in the distribution of insurance weren't really getting much better. So structural racism is basically, we're not going to be talking about decision-making and bias and things like that. We're talking about what exists beneath all of this. And structural racism are basically institutional practices, public policies, laws, regulations, all of the things, all of the norms that are created in society that sit behind everything. It's the normalization and legitimization of all of these dynamics: historical, cultural, institutional, interpersonal. And actually, it's the one thing you really have to fix before you can actually hope to see any kind of changes in disparities. And that's why I sort of focused on this. So what we're going to start with, the first thing I want to start with is something to think about: disparities in Medicare. And so remember what I told you about Medicare and who lives to be 65 years of age. So you look at this chart, and basically you can see the percentage of 25-year-olds who won't live to be age 65. Again, this is data that we sort of extracted from the background charts that support this. And basically what it says is that if you're a white male, you have a 17.7% chance of not living to age 65. But if you're a black male, you have a 25.1% chance of not living to age 65. So big discrepancy in the percentage of people who are going to live to age 65. And what that means is that people, if you look at your paycheck, you see that all of you contribute to the Medicare Trust Fund all the time. And guess who's going to benefit from the Medicare Trust Fund? It's a majority of people who are white, who end up living long enough to be on Medicare. And it's not that many years ago that the life expectancy of an African-American male in this country was only 67 years. And so when you think about that and the fact that people are contributing to the Medicare Trust Fund all their life with a much lesser expectation that they're going to ever benefit from it, there's a disparity that's baked into the structure of the system. So another huge issue, and one that I think is really one of the heights of the pathology in this country, and something that's really got to be changed, is the differential payments between Medicare and Medicaid. So Medicare for the elderly, remember, predominantly white, 82% white in this country, and Medicaid for the poor, which has an overabundance of people of color. If you create a healthcare system, both of which are operated out of the same federal agency, CMS, but one of which guarantees across the country a payment rate that pretty much allows people to access care wherever they are and whatever they need, and that's the Medicare system. So let's look at the difference. So in the ACA, the ACA included a mandatory 2-year increase in fees for primary care services to Medicare levels. Now, why would they do that? And for Medicaid, both in fee-for-service and Medicaid managed care. This was called the fee bump, and it's since expired. So for a couple of years, across the country, states had to pay for Medicaid patients exactly what they were paying for Medicare patients, and there was a huge increase in access. However, this was not one of the parts of the ACA that was renewed under the current administration. So let's see what happens. So this is an index of Medicaid to Medicare fees. And basically, you can see that the light blue areas are where the lightest blue areas are where the index is, between 0.38 and 0.42. That means Medicaid is paying between 38 and 42% of what Medicare pays. And then you see the dark blue areas where Medicaid is paying almost as much, and in some cases, even a little bit more than Medicare. And this doesn't exactly fit the pattern of red and blue states, which I can't quite understand, except that the Medicare rates are geographically adjusted, and I think the index represents changes in the Medicare rates as much as it does the Medicaid rates. But if you look across the country at the range, just look at what a 99213, a regular office visit. In one state, in the lowest state, you get paid $20.64 for that. And in the highest state, it's $118.70. You look for an initial hospital visit, and in one state, people are being paid $29.50 for it, and in another state, $236. So there's huge discrepancies between Medicare and Medicaid, and that represents a built-in prejudice in the system that we really don't need to guarantee care for people who are poor on a national level, but we do, but we do for people who are elderly. Also, think about the political power of elderly people who vote, and at least traditionally, a lot of people who don't vote who are poor. And so you end up with this kind of system. Remember, both of these systems, Medicare and Medicaid, were both were both brought in the 1960s, a year apart, but through very different sort of political background. So we also maldistribute health insurance. That's another big piece of where the problem lies. And so if you just look at this slide, you can see if you're white, non-Hispanic, you're only 13% of you are uninsured. But if you're African American, 21%, Hispanic, 32% of Hispanic people in this country are uninsured. And this is only, if you remember the slide I showed before, it's only changed slightly. All of the numbers have gone down a little bit, but the disparities haven't really changed. And so we know that people who are uninsured have no usual source of care. They postpone seeking care, they go without care, and they don't get their prescriptions filled as frequently as people who have insurance. So what are some of the results of this in terms of what happens? And here we turn to some information around New York. So each one of these bars, this is data that I took from the Sparks database. So every discharge in New York State is reported to the Sparks database. And if you take this, I updated this in 2016, but I actually did this for the first time about 15 years ago. And it looks pretty much the same as it did 15 years ago. But every bar represents the percentage of each hospital's patients who are on Medicaid or uninsured. The dark blue area at the bottom are uninsured, and the yellow bars are the folks who are on Medicaid. The little arrows at the top and the left are public hospitals. So any bar that doesn't have a little arrow is a private hospital. And so what you see here on the horizontal line, the lower horizontal line represents the percentage of New York City's population that are uninsured. And you see that there's only one hospital that serves a percentage of people who are uninsured that's equal to or more than the percentage in the population. So if you think about this across all the hospitals in New York, we are underserving people who are uninsured. You're less likely to be hospitalized. I don't know, maybe that's a good thing. But but it's not for good reasons, as I'll show you in a minute. But if you look at the top horizontal bar, that bar represents the percentage of people who are uninsured or on Medicaid. So any yellow bar that doesn't extend above that are underserving the population of people who are uninsured or on Medicaid. And so all the public hospitals are at the top. And there's only four private hospitals in New York City that actually take care of a proportion of people who are uninsured and on Medicaid that's greater than the population in the city. So all of these other hospitals here are getting away with lots of subsidies, which I'll show you, and basically lots of subsidies, and are not doing their job as good healthcare citizens in taking care of the folks in New York. Well, I was really curious as to who these bad guys were up here. And so this is who they are. And the interesting and sad thing about this is that it represents all of sort of the single-purpose specialty hospitals. Calvary, which is the only dedicated hospice, Joint Disease and Hospital for Special Surgery, which are the only dedicated orthopedic hospitals, Sloan Kettering, which is the only dedicated cancer hospital, and the Rusk NYU Rehab, which is the only dedicated rehab hospital in New York, all are at the bottom of the list. And so the Sloan Kettering had asked me a few years ago to come and talk to them about why they had such a low percentage of people on Medicaid, because the state was denying them some of their permits to expand into other areas until they increased their Medicaid percentage. And I said, well, I showed them this data, and I said, well, you really are at the very, very, very bottom of the list. And yet their advertisements, which, imagine how sad this is, that their advertisements basically say where you get your cancer treatment, where you get your first cancer treatment may have everything to do with what happens to you. But then think about people who are listening to that and don't have access to that institution, or to special surgery, all these other places that are advertising on billboards all over the place. So they're not really, these are the places that are doing the worst at taking care of people who are on Medicaid and the uninsured. But what's even more sick is how we've been able to make a healthcare system in New York, and this was the same in Chicago where I studied, where basically hospitals, private hospitals and public hospitals are built next door to each other. And they do that. If you're a private hospital, it's the best thing you can do is open up across the street from a public hospital so that you can make sure that all the uninsured patients and the people on Medicaid get shifted over to the public system. And so Montefiore and NCB Moses, look at this is the same yellow and dark bars that you saw before, with the uninsured is the black, the yellow is the folks on Medicaid. Huge difference in where the uninsured end up in the Montefiore NCB sort of axis. These hospitals are, for those of you who don't know, are actually connected. Each hall is connected across, and when some of us were residents there, we literally used to wheel the patients who came into one ER if they needed to be admitted and they were uninsured or on Medicaid, they would get wheeled through the hall to the public hospital. Jacoby and Montefiore Weiler, which are basically a couple blocks apart, NYU and Bellevue. I mean, look at the percentage of Medicaid that NYU has compared to Bellevue. And then here's our own darling Mount Sinai, which, really, if you think about it, we can talk all we want, right, about the little bar and all the uninsured people we take care of. And there's no question that no matter how little this bar is, it does have a financial burden on the institution, but not as much as a financial burden as it has on the public hospital system. and look at the difference in the percentage of people on Medicaid who were admitted to the two local hospitals compared to Mount Sinai. Now, the public hospitals do have subsidies, but I'm going to talk about those subsidies in a little bit too. So we know that there's an inequitable distribution of the burden of care on the uninsured, and now we're going to look at some of the subsidies. So this is research that, this is about a third of a spreadsheet of the research that I've been doing over the last year, which is accumulating all of the financial information on all of the subsidies that the hospitals get, and also looking at all the financial information on the reports that the hospitals file with various federal and state agencies, some of which you can get through the Freedom of Information Act, and some of which you just have to hunt through and get, and some of which I got from a friend in Albany. And so, right, who shall remain nameless. So if you put all of this stuff together and you start to look at what this means, hospitals are always complaining about their subsidies and about the fact that that charitable stuff that I showed you before, that this work is really, costs them a fortune and whatever. But hospitals have to report on their Medicaid losses, like how much do you lose? What's the difference between what your cost is to provide bypass surgery for a patient and what you get from Medicaid. So there's a gap there, and you have to report that gap. And the same gap has to be reported between the patients who are uninsured and what you get from people who are uninsured. And so when you report that, that's where all of this data comes from. And then the state and the federal government report on their subsidies to these institutions. So I thought, let's just plot these things together. And I added up all of the subsidies with all of the losses that the hospitals report. And something really unusual occurred. This line represents, if you see, it intersects right here at 100 million, 100 million, 200 million, 200 million. So basically, this is the line where any hospital that's on or near this line basically gets this amount of subsidy that it reports it needs to completely make up the losses for those patients. So you can see a lot of hospitals along this line. That red dot is Mount Sinai, right on the line. So basically, it's getting back in subsidies all of the funds that it reports it loses. Now, that doesn't mean that they wouldn't make more money if the beds were filled with privately insured patients. They would. But it also doesn't mean that people are actually losing money. They're losing opportunity cost, but they're not really losing money on this. But I also noticed that there's this weird thing that Jacobi and Harlem Hospital and Elmhurst and Woodhull and all the public hospitals were sort of falling off in this other area here. And if you just realize that, you can draw another line, and this line actually intersects at a place where every hospital loses $50 million a year. So there's something about the formulas by which these hospitals are reimbursed that basically says, however these places are reporting their losses, that the public hospital system is not recovering the amount of money that it reports as losses, whereas most of the private hospitals are. And when you get down here, the numbers are so small that it really doesn't make any difference, but you can explode this area as well. And the people that are really losing money on caring for the uninsured and on Medicaid, you see how big this cluster is down here, are the small hospitals that are here that basically are not getting the subsidies, but all these big institutions. And these are the places where a lot of the political power lies in terms of the healthcare system, with the Greater New York Hospital Association and other very politically powerful networks of institutions. So now that we've seen that, where are all the uninsured patients being taken care of? Well, in New York City, 68% of all the hospitalizations for the uninsured take place in the Health and Hospitals Corporation facilities, and 35% of all the Medicaid discharges take place there. So what's the end result of this? The end result of this is that the private hospitals like Mount Sinai, NYU is always the big winner. They earned $278.4 million from operations for last fiscal year, and operating profits that grew by 21.6%. Meanwhile, Health and Hospitals Corporation, it was projected to lose $1.3 billion last year on the same piece. So another thing that hasn't made me too popular is I've been sort of espousing the idea that actually there should be an assessment made on the private hospital system to help support the public hospitals. Now, what's the rationale for that kind of an assessment? The rationale is the only reason the private hospitals can be profitable is because of the people from the public. That is the fact that they can offload the responsibility for taking care of people on Medicaid and the uninsured to the public hospital system. If it wasn't for that, they wouldn't be profitable. So it also makes a difference where people, this study was actually done in Mount Sinai. It makes a difference where people get their care. And the reason I just put this up is because Elizabeth Howell, who's at Sinai, did this study, which basically said Black women are 12 times more likely to suffer pregnancy-related deaths. And that disparity in New York City is 4 times greater than what it is in the United States as a whole. But if Black mothers delivered in the same hospitals as white women, the model says that there'd be 940 fewer morbid events, and it would decrease by 47.7%. So why is that? It's not that the walls of the hospital are bad, it's that the hospitals are underfunded, right? And underfunded means older equipment, it means less staff, it means all kinds of things that lead to the inability to deliver the same quality of care as hospitals that are well-funded. And so we have to worry about the funding for the public hospital system because that's where the people that we take care of in community health centers basically oftentimes end up getting their care. So another place where there's disparity is really in how facilities are built. So one of the crazy parts and that allows facilities to sort of differentiate in their care between public and private patients, between people on Medicaid and people who are privately insured, is that hospitals and community health centers and anybody licensed under Article 28 of the Public Health Law have 7 volumes of requirements that they have to meet in order to run a practice. That's what we meet in all of our health centers, all of this stuff that goes on. You can open a private practice and there's no health department rules or regulations that come to play. Nobody comes and inspects your facility. Nobody comes and looks at your architectural plans. None of the things that you go through to build facilities that enable you to get higher reimbursement rates for Medicaid, actually, none of those are requirements for people in private practice. The reason that's so bizarre is that it means that we have set up sort of 2 different places for people to go, right? One that's easy to open. You rent an office, you put in an exam table, you can go to work tomorrow morning and start seeing patients. You want to open an Article 28 facility, a community health center, a hospital outpatient department, you're looking at a year's lead time just to be able to go through this, and costs for all kinds of crazy things, ventilation systems and fire exits and all these things, all these requirements that are put on. Meanwhile, all the people that get care in private offices there's no oversight for those practices at all. There's no quality oversight. There's no oversight in terms of the facility construction or anything like that. So all of those expenses are being put on these institutional systems. And you'll see why that's important. So I'm going to pause for a minute and just go back to my medical school days. Apologies to some of you who've heard this story before, but this was Presbyterian St.Luke's Medical Center in Chicago when I was there in 1974. And it now looks like a spaceship. It's really the most bizarre looking place I've ever seen. But it's I was there as a medical student. And Pres St. Luke's had separate public and private floors. So the Medicaid patients for medicine were on one floor, the private patients were on another floor, and OBGYNs, there were 2 floors, one for the public patients, one for the private patients. The whole hospital was sort of built on that model. And interestingly, we were only 2 blocks away from Cook County Hospital, which was unlike in New York, there was only one public hospital in Chicago, and that was Cook County. And so it was huge. It was like 3 blocks long. And so we were across the street, but we still had our share of quote, public patients. And I was in Cook County, I was at Press one night, and I was on my OBGYN rotation, which I think was the second rotation that I was on in medical school. The first was transplant surgery that I drew out of, and I spent my first month basting kidneys that were being transplanted in the transplant center. But the second month I was on OBGYN, and one night I was on the floors, and the nurses came up to me and asked me if I could help them distribute medications. And I thought, that's sort of a weird thing, that for a medical student to be doing. And so I asked, why they needed me to help. And they said, well, we have no registered nurses on the floor tonight. And this was a floor of, I think, 38 beds. And so the nurses were asking if I could help them distribute medications. Meanwhile, we got into a conversation while we were doing that and found out that upstairs on the private floor, actually it was down the hall, on the private floor, there was basically 2 registered nurses on, but they were basically only taking care of the private patients. And so I stole the nursing schedules from both floors, the private and the public, and to see whether or not this was sort of just a weird thing that was going on. When you're interested in social justice issues, you find all kinds of opportunities to sort of discover things along the way. And so this is an actual copy of the index card that I made, without the red circles. But 7 East was the private floor, 7 Jones was the public floor. And what you could see was that they both one had a census of 28 patients, the other 30. But there was 1.6 RNs per shift in the private floor, 1.1 RNs per shift in the public floor. And at night, there was a tremendous problem. If you see in the same size floors, there were fewer nursing shifts through the whole period. And in fact, multiple days where there were no registered nurses. I thought, that's really bizarre. And so I brought this to the nursing office, and I said, I don't understand how you guys screw up on these schedules all the time, but the floors that we're on, which are the public floors, the only floors the medical students were allowed on, I said, what's going on here? And they said, well, some of the patients pay privately for their care, and some of them are paid publicly. And so you don't expect us to pull nurses off of private floors where people are paying for care to take care of people who are being paid for by the government. And of course, that philosophy still exists today. I mean, really, private patients still get different care than public patients. But when you have discriminatory practices like that, it's a setup for bad things to happen. And it's still, to this day, a setup for bad things to happen. So what happened here was I was basically not scrubbed in, but I was basically watching a cesarean section. And in a C-section, most of them were done back then under general anesthesia. And the idea when you do a C-section under general anesthesia is you put the mother to sleep and you deliver the baby as quickly as possible. If the baby's not delivered quickly, the baby ends up getting the general anesthesia, and they come out all floppy, and you have to slap them around a lot and give them oxygen to get them back in shape. And so I had seen a C-section, and it was really interesting. This was kind of like a contest for the OBGYNs to see how fast they could deliver the babies. And the standard was to get the baby out within 3 minutes of the induction of anesthesia. So I'm watching one of these C-sections, and the surgeon basically does the incision, they open up the belly, and they don't deliver the baby. And the surgeon stands up and walks to the other side of the room, folds his hands like this, and another person who's scrubbed in comes and starts taking blood tests from the uterine artery, the uterine vein, the radial artery, the radial vein, comes in with all these syringes, and they're doing all of this stuff. And about 7 or 8 minutes later, he steps back, and then the surgeon comes in and delivers the baby. And not surprisingly, the babies are all like this when they come out, and they're all being resuscitated with oxygen and whatever. I thought, this is really bizarre. So I thought there was just something that had gone wrong with the mother. But the second time I saw this, I started asking questions. And then I started asking questions of some of the other students who were on the rotation to see if they had seen this. And they said, yeah. And so we asked the surgeon what was going on, and he was involved in an experiment to see what the oxygen levels were in these different arteries and veins. And when I asked what they were doing and if the women knew that their babies were being affected by this, he said, oh yeah, they're all consented and everybody knows what's going on, and they all, this is an experiment. That's the way we do experiments. So I did what every well-meaning medical student would do. I actually went and interviewed the women, and none of them knew a thing about this. There were no consents, there were no written consents, there were no verbal consents. Nobody had any idea what was going on. And so we reported this to the chairman of OB, who knew all about this experiment, thought it was the coolest thing that they were doing in OB, so was not at all concerned, and said that nothing had gone wrong with any of the babies, except that one of them was in the neonatal ICU, and we pointed that out. And then we went to the dean of the medical school, and then we went to the president of the medical school, and nobody really wanted to do anything about this. But what I had done, sort of to protect ourselves, was I had taken the patient's charts off the floor momentarily to the library, put nickels in the copy machine, and I copied the anesthesia records and stuff to show that these children were being born after prolonged anesthesia. And so when we brought this to the president of the hospital, my friend and I were both suspended from medical school for copying patients' charts, which we thought was kind of bizarre, that that's what they were most concerned about. And I went to a mentor of mine who happened to be a professor of radiology, and he was a very well-meaning guy who'd been involved in a lot of radical politics in the 60s, and he said, you gotta go to the newspapers. And so he said, the only way you're gonna get your job back is to go to the newspapers. And so basically, we went to the newspapers, and the black newspaper the next morning said hospital tests on 4 women hit, and basically had the whole story of how these women were being experimented on. And then next day, it came out in the Chicago Tribune, which is the main newspaper in Chicago. And after that, my friend and I, who reported this, were both appointed to a new human experimentation committee at the medical school, and were told how thankful they were that we were able to speak out, but always denied that anything wrong had been done. And the researcher was fired, which he should have been, and ended up at Loyola, which was just another medical school in Chicago. And the medical students there, because we had a group called Concerned Medical Students, the medical students there picked up on the story that we had and had a huge protest when they heard that this guy was coming there, and ended up getting him fired from Loyola. And this was a terrible thing that was going on, and it turned out was just the tip of an iceberg of all kinds of experiments and things that were happening in this institution, which, if you think about it, it was largely a research institution, but because it had a mix of private and public patients, it had experimental folks that they could experiment on, and still do all of their research and everything. And when I gave a talk about a year ago at Bellevue to the emergency medicine department, somebody came up to me afterwards and said, the same thing is happening here. They said NYU has all of these research protocols that they do through the medical school, but they're doing them here at Bellevue. And I said, gee, that's exactly the same thing that happened 30 years ago when I was in medical school, but all within the same hospital. And they said, yeah, and we don't get the indirect funds at Bellevue. They're all kept at the medical school. And so they're using the patients at Bellevue as for the experiments that they're doing, but the grants are coming into NYU, and those and those funds are staying there. And so, we think that these are sort of old tales, but they're still happening. They're just happening in slightly different formats. And so we know that, that people are getting care in different places, and they're getting different types of care, both here at Sinai and elsewhere. In every academic medical center, they run separate faculty practices and clinics. Completely the same thing on the outpatient side as we saw on the inpatient side, where in the clinics, you're taking care of the uninsured patients and people on Medicaid. In the faculty practice, you're taking care of the privately insured patients. And they differ in almost every aspect, in continuity, in coordination of care, in night coverage, where if you call at night and you're being cared for in a private practice, you get a doctor on call, but oftentimes in the clinics, you're just told to go to the emergency room. Another reason why our emergency room usage is so high. And this is a study that some students did here a couple of years ago, which show there's huge differential access. I think many of you have probably seen this before, that just shows waiting times to get an appointment between the clinics and faculty practices. And one of the crazy parts about that is that if you can give a patient, this is data from our own Harlem Family Health Center, if you can give a patient an appointment that basically gives them a specialty consult within 2 days, 80% of the people show up. If you get to 30 days or more, only 12 or 15% of the patients show up for their appointments. And almost all the clinics are over 30 days in terms of waiting time. So one of the problems we're having with our own referrals now is that very many of our patients don't show up, but that's because they're waiting 30 to 45 to 60 days to get an appointment in a specialty clinic. So these are all continuing problems in terms of quality care of what we can do. This is something that Red and I have been talking about lately, and I just want to highlight this because it's just another place in which discrimination comes into the system. And this is sort of, if you think about it, in acceptance to residency programs. So there's a lot of racial bias if you use the USMLE Step 1 scores to grant admission to residency. This study was done in internal medicine residencies. It concluded when you use Step 1 scores to screen applicants, a significantly greater proportion of African-American students will be refused an interview. Why? Because all of these standardized tests have a cultural and a language bias. And so just traditionally, people of color do worse on these standardized tests than others. And so if you use them to screen, you end up with a disproportionate percentage of white people being asked to come for an interview. But there's another reason, and that has to do with the ACGME regulations that basically say that accreditation is dependent on first-time board pass rates. So if you're basically looking at an applicant who's basically failed their USMLE twice, but passed the third time, or even failed it once, and passed the second time, and you're a residency program that doesn't have 100% of your people passing their boards on the first go-round, you're much more likely to look at an applicant and say, gee, is this person going to affect my accreditation and because they may not pass their family medicine boards the first try. Maybe it'll take 2 tries, maybe it'll take 3 tries. And so we've been encouraging folks, in our own programs, but I think we still have to do a better job at this, of not, of fighting this recommendation, because it is a recommendation that flies in the face of opening admissions to folks who've done a lot of great stuff in the community and whatever, but it's taken them a couple times to pass a board exam, and so you have to look them over if your accreditation is in jeopardy based upon board pass rates. And the matching program actually does its own survey, and it said the factors most commonly cited for selecting candidates to interview were the USMLE Step 1 and Step 2 scores, followed by letters of recommendation, performance evaluations, et cetera. So we've created a system, we've put an accreditation piece in that basically helps to select against people of color and coming into graduate medical education programs. Just another piece of the story. So I'm going to end with talking about some research we've done here, and I want to acknowledge my research collaborators, Diane Hauser, who's been working on this project with me for more years than she would like to admit. You'll see some data that Casey Crump, our vice chair for research, has been working on with us most recently. Eve Waltermauer, you'll see some of the data. I'll point out some of the stuff that she's helped put together just very recently for us around diabetes. And so diabetes is a huge scourge in our population that we take care of, and you can see some of the impacts of disparities. So this was the starting point of our adventure into trying to figure out why the Institute had disparate outcomes in diabetes. So we think we're great and we take care of everybody the same. They should all get the same results. But years ago, we did this and saw that people's last A1C varied by race. And this was a terrible thing to find out in a program that swore that they were taking care of everybody the same way, and would, we expected to see that we were unlike the rest of the healthcare system, and we had eliminated disparities. So we looked at all the things that we were doing differently in these populations. We were actually seeing Black and Latino patients more often than white patients, and they were getting more medications. So we couldn't really understand what was going on. We looked at about 20 different characteristics. But what we found out is what was happening in our practices was exactly the same as what was happening in the country. Everybody was getting better when they came to the Institute for Family Health. Their diabetes was improving. We looked at their first A1C and compared it to their most recent A1C. But the lines were parallel, more parallel than we would like to see them. We were not diminishing the disparities in care at all. And you start thinking about, what does this mean? Well, what it really means is that when people come into care, they have a whole history behind them. First of all, they're possibly in different social and economic environments. We know that people of color are undertreated oftentimes and don't have the same insurance and don't have the same continuity of care. And so all of that stuff historically means that people are coming in at a higher rate. They're coming in with higher A1Cs, which means they're not as well in control as the white patients who are coming into the practice. So if you come into the practice and everybody gets better, you're not going to do anything to really remove the disparities. And if you think about it, we kept saying, well, you got to do something extra. What do you have to do extra? And we developed this thought that this is kind of like affirmative action. And so we did a bunch of things extra, but we didn't do it just for people of color. We did it for people who had A1Cs that were over 8. And basically what we did is we set up a registry. We had disparity reports. People could see what their rates of control were for their diabetic patients of color compared to white patients. We could do this by site across the Institute. We hired diabetes educators with the help of the Robin Hood Foundation. We had a diabetes medical director. We did all these things, and we just targeted them to people who were above 8. And this goes back to I think we started this in 2004, right, or 6, something like that, somewhere around there. And here's the results of what happened. So this is people whose A1Cs are greater than 9. Now remember, this is a cross-sectional study, so we did not track individual patients. So if you looked in January of 2009, these disparities existed between our white patients, our African-American patients, and Latino patients. These disparities existed. And if you see over time, this is between 2009 and 2012, over this 3-year period, the disparities pretty much went away, and they've been wiggling around, but up through 2015, they're pretty much in the same place. And you could look at this for people whose A1Cs were less than 7, which at the time was the goal. It isn't anymore. But A1C is less than 8. And you could see disparities getting better, in some cases improving, and in some cases getting worse. One of the reasons why the data sort of separates here is this is when the Harlem Family Health Center opened up. And so we ended up with a whole slew of new patients who hadn't been treated before. But prior to that, pretty much the disparities had gone away completely. And so here's another, this is nephrology screening. And you can see that this is blood pressure. No improvement in blood pressure. And the interesting thing was when we did this stuff, we really didn't pay attention to blood pressure. We were really only looking at A1Cs. And this is kind of like our control, I think, is because we didn't really pay attention to blood pressure, which we now know is more important than A1C, but basically sort of served as a control. And this was just, Casey actually, I think, wrote this paper, even though my name is first. This is a risk-based intervention approach, and this basically showed, again, just this graph is from the paper, and shows that 4-year time interval where the disparities that were started out basically were completely eliminated. And they were eliminated because we were doing more for people who needed more, right? And not doing the same thing for everybody. And that's gonna be a theme. Then Diane and I worked on this paper with Eve and others back a few years ago and published this paper on the transition. And one of the things that I didn't point out on what we did differently was we set up really teams of people, including the diabetes educator and roles for nursing and other folks. And what this paper showed was that as we tracked visits, the visits for the providers actually went down while the visits for other team members went up. And all that time while things were improving across the system. And Eve just sent me this data about 2 weeks ago, 3 weeks ago. And what she did was she looked at, this is something I didn't even think about doing, but in the data that we had collected, remember these were cross-sectional views, the one failure of that was we didn't track individual patients. And so she went back and looked at individual patients, and she tracked only the patients who had had at least one A1C a year for all the 9 years of the study. And it turns out that it corroborates exactly what we had found before, which was if you track the individual patients, we literally eliminated this disparities between these populations by doing this extra stuff. Have you seen this before? I would put a poster of this up on my wall. I think it's the most important concept in medicine these days, which is the reality of what happens, and this is what and this is what's happening in our hospitals and in our healthcare system, right? The people with the most get the most, and this is the worst part of the system. But even if we could achieve equality, we'd still end up with the same problem, because we would still end up, just like we did in our diabetes study, we'd end up with people who don't achieve the same outcomes. They all get the same thing, but they don't achieve the same outcomes. And this is really what we did in the diabetes study. We took people who had a historical disadvantage, and we did more for them, and we were able to get them to achieve the same outcomes. So I point this out because this is just how far we still have to go, right? I mean, we're here, and we have to get here, and we can't even get here. And so, and all of the structural things that I talked about in terms of the healthcare system aren't even getting us to a point of equality. So to get to a point of equity, we're so far away from that, but we have to keep thinking about it, because that's what's pushing, that's what we have to keep pushing in order to think about ever being able to sort of address the issue of health disparities. So this is work from the Bronx Health Reach program. We published this monograph. It showed that, and we filed a civil rights complaint against the Attorney General's office for differential treatment in the hospitals. Maxine Golub and Charmaine Ruddock were key partners in this endeavor. And we worked on this for many, many years and are still working on this. And this made it to the newspapers as well. I think that what's happened is there's been an increased interest in people addressing this issue openly in institutions. And I know here at Sinai, there are a couple of new committees since the students have been talking about this, and since people have been thinking about disparities in care. There's some new committees set up that are beginning to look at this. I don't think we've made dramatic changes yet, but The fact that people are talking about it and that people are recognizing it, and the most important fact that medical students are understanding and residents are understanding these problems and these issues, because remember, we're training the next generation of people in an environment where we're teaching them that it's okay to take care of people differently, based upon their insurance, based upon race, based upon where they get treated. And that's part of the terrible part of this whole thing. So we're still working with people in the Bronx, with the Bronx Health Reach program, and our ultimate goal is to make health equality a reality. That's really what we're trying to do, and you can see how far we have to go from where we started, and I'll just leave you with the point that it's gotta start with the structural pieces. You gotta do away with the inequities in payment systems and hospital subsidies and all of these things. You gotta deal with the structural piece of it, because if you don't deal with the structural piece of it, this isn't about me and you wanting to do the right thing. It's about having the resources and the institutions and stuff like that that support that. So I'll end there. I think we have little time for questions, maybe a couple. Thanks.
Thank you, Dr. Calman. I was struck walking in today, walking past the big posters in the lobby touting Mount Sinai's commitment to diversity, when we in fact are a highly structurally racist, segregated organization in terms of some of the things you mentioned, in terms of people of color who are overrepresented in Medicaid populations being seen in totally different clinics, which we have objective data showing worse outcomes, and we all know instinctively that separate is not equal. What will it take? I mean, we all know this, we all practice within this system. What will it take to actually make organizations like Mount Sinai, which claims to be progressive, which claims to have a commitment to diversity and the underserved, to actually make these structural changes?
I don't know who wants to answer that. I think that institutions stand behind their reputation, and you can't do anything unless you do something that challenges their reputation. And I think that the most terrifying thing that we did at Mount Sinai, that the medical students did at Mount Sinai, was say that they were going to hold a public forum. I mean, nothing has gotten as much attention than the call for a public forum in the community to talk about disparities in care. And I think that just like the newspaper things that happened when I was in medical school and the stuff that happened at Bronx Health Reach, that there's got to be a public awareness. We got to build a public awareness of what's actually going on. And I think, as many people as can understand the structure and how much it creates the exact outcomes that we would expect from an inequitable system, I think we have to stop talking about, I don't even use the word health disparities anymore. It's really not about health disparities. It's about racism. It's about the systems part of it, because health disparities are like the symptom. It's like the headache. It doesn't really tell you anything about what's going on underneath. What's going on underneath is structural racism. It's basically institutions, practices, laws, regulations, all of which are racist at their core. And unless that stuff is fixed, we're not going to get anywhere, with the individual institutions. The other thing I think we have to stop doing is victimizing individual institutions, because the pathology is not at Sinai, it's not at NYU, it's in the structure of the way all of these institutions practice. And so when we were very clear when we did the Attorney General's complaint to name all the institutions, because, you don't want one of them going like, oh, look at those guys, they're the bad guys. It's really not that. It's like they're all bad guys. And we're all bad guys because we haven't fixed this stuff yet. Brad?
Thank you. What I'm struck by is you opened basically with a story, your story. And if you think about just what's happened around sexual harassment and abuse, really within the last year in this country, it's the stories that have gotten people's attention. Mm-hmm. And perhaps one of the things that we can do as physicians is collect these stories I mean, if we could, thinking just about the assessment that we have with our patients, and formalize a way of collecting information about what their experience is of being marginalized, and then figure out how to way to get those stories out, because you're absolutely right. This is about embarrassing people, embarrassing institutions, and embarrassing politicians in this day and age, that this should not continue. And what we sit on as a profession is all these stories. So I just sort of, I'm struck by your presentation and the power that stories have had in really doing what you're describing, which is making this a movement. Which is it's a hard thing for those of us who've been at this for a while, just to get community organizations around this as a movement. But sometimes stories do that. I don't know, just your thoughts on it.
Yeah, no, I think so. And I think the other thing that, you know, when I talk to medical students, I tell them to start journaling and to journal now. You know, start writing down the things you see, because people become immune to this stuff after a while. You don't even see it. You're living in it and it's all around you, but you stop seeing it in the same way. And I think that that's really, it's important that people continue to see it. And one way you do that is to write it down. Somebody else, yeah, hi.
Hi, good morning, and thank you so much for your presentation. I've never spoken up in this setting, but in one of my agency, I probably have the reputation of an angry Indian woman. This is going to work thinking about, does anyone care? You know, I came this morning thinking, are we really going to be talking about social justice here? So I really commend you for bringing out a lot of things that are important. I am a mental health clinician at the Family Health Center of Harlem. I work there part-time, so I have a lot to lose here. I'm afraid that I will even lose my job for speaking up. But at the same time, we've all agreed that this is all pervasive. So I also work in another clinic, but part of what I've noticed, I'm also a biomedical scientist. So part of what I've noticed is even things such as electronic medical records. I'm only speaking about mental health care. I'm not talking about medical, which I don't know anything about, is that there's the electronic medical records system, so-called evidence-based practices, outcomes-based research. All of these are as much as important as they are, they're also very problematic, particularly for mental health care, where so much of time is taken away from the patient, and a patient's being interrupted every 10 seconds. Especially when when there's a lot of discontinuity in services and patients haven't seen a provider in the longest time. My dream is to help work with all of us to help improve this in terms of mental health care, where a patient has to answer 100 questions or so, or more, and a myriad of questions of arbitrary measures, especially reification of highly subjective processes such as depression and experiences, is highly, highly problematic. It's somewhat of a wrecking ball as a clinician to have an alliance with patients.
So part of what you're talking about is very similar to what I was talking about with the requirements on practices. So if you're a mental health clinician in a private practice, you sit down, you can have a conversation with somebody, you can meet with them face-to-face, you can write some notes in a chart, and you can put them in your file cabinet and lock it up at night. When you're in an institutional setting, and you've probably been through some of the audits and stuff like that, you know, you have a team of 8 auditors that come in and spend a week in your place, and they want to make sure that for you to get funded, every one of those 100 questions has to be answered on every one of your 100 patients. So if we create these systems with all of these obstacles in there, and we deal with this all the time, the administrative burden of the regulatory system is something that helps to continue to support these disparities, because they put all of these regulations into systems that the health department regulates. But if you were to go into private practice and do the same thing you're doing, you wouldn't have any of those restrictions, and you could practice the way you are. Now, some of those things are good, because there's a lot of really cruddy providers out there in the world, and you see them losing their licenses and doing other things for things that are not, where there's no oversight ever into their practices. So somewhere in the middle, between those two extremes is where we need to go. So,
Thank you.
any other questions?
Hi. So I think what really stood out for me, you made a statement that says we think that these are tales, and to me that was very poignant because I feel as though even in the 1970s when that newspaper came out, I think that these disparities and these systemic problems aren't highlighted, and there are people who, in the community, people of color who would like to stand out and speak against these systemic changes that we see, but we feel as though we don't have a platform to do so. So what would it take, in your opinion, for the people who have been standing out and speaking against these disparities for years? What do you think it's going to take to stick? Because you're doing an amazing job of highlighting these systemic changes that need to happen, but I don't think it's sticking. What do you think is needed for that to happen? Because it's being brushed over, I think.
I don't know, what does it need to change global warming? I think we have to be responsible for speaking out against injustice every place we see it and all of the time, no matter what the personal cost. I think that's basically it. Do you want to go through life and kind of slide through, or do you want to go through and feel like you've accomplished something? So for me, I feel like the platform when I was in medical school was we formed a group called Concerned Rush Medical Students. And we used to put on seminars once every quarter in the hospital where we would invite people to come and speak on controversial topics. And interestingly, it wasn't just for medical students and for residents and for physicians, but we would invite the entire hospital community. And the clergy would come, and people who are working in housekeeping would come, and we would do it in the evening so everybody could come. I think everybody in the organization, in these organizations, needs to understand all of the things that are going on. This isn't just a doctor thing, it's everybody. So that's one thing. And I think the second thing is, you need to develop a presentation and give it as many places as you can. I've probably talked about disparities, hundreds of times in different venues, and some places where I was invited and some places where I wasn't. But it was just, you try to tell the stories to as many people, because people who begin to understand the story are more powerful in bringing coalitions of other people together to be able to do something about it. But you can't do it by yourself. You have to have a group of people. And I've been fortunate, to work in an organization where a lot of like-minded people work and who are all struggling against the same thing. But not everybody has that good fortune. So sometimes you have to put those groups of people together wherever you work and find people who are like-minded and start addressing some of the things there are. But don't take for granted the fact that, and I don't take for granted the fact that, my white privilege gives me an opportunity to speak out about things that sometimes other people would not be able to do. And so, so I think that's important. And I also think it's really important to be the best at whatever you do, because that gives you privilege too. If you're struggling, to get through medical school or to get through residency or to do whatever you're doing, it's harder to have a platform to be able to speak out than if you're, recognized in some position, either through a group or through your job or something, to be able to do that. So just, it's gonna be a long haul. It took us hundreds of years to get to this pathological place we're at, and we're not gonna fix it overnight. But I think we all have to address it every day, wherever we are, wherever we work, and every time we see something bad happen. Yeah, Gabe.
Gabe Guadaramas, Family Medicine. Have you tried utilizing the legal system
Yeah.
to end institutional racism within the state of New York by, let's say, suing the New York State Department of Health, which is where the tire hits the road and gives all these hospitals their licenses?
So we actually filed a complaint against these hospitals with the State Attorney General's office, a civil rights complaint. The interesting thing about that is, and again, think about how slick this is, that if you talk about disparities in treatment or you have to be, you're comparing Group A to Group B, how these two groups are treated, right? Well, it turns out that when you look at the clinics and faculty practices and you go and you file a suit about that issue, how can an institution have two different groups of people doing two different things? The health department points out that they have no authority over the private practice of medicine. So the faculty practices are structured in such a way that they're private practices. Even though they're in institutional settings, they're structured in a way that they're private practices. So private practices are governed by the state education department, not by the health department. And the clinics are governed by the health department. So you have the health department saying we have no control over the faculty practices. And that literally has been their response since we've been doing this for decades, basically said we have no control over the faculty practices. We contended that a patient doesn't know the difference between whether they're going into a Mount Sinai faculty practice or a clinic, that's just, that they don't know. So if they don't know, then they should all be governed the same way, right? If it's not publicly detectable that you're in different places. But at any rate, we've tried this process. We were told that it's kind of a dead end. There are lawsuits all over the country around discrimination in healthcare, and they sit in the courts for years and decades and never sort of get anywhere. By the way, the Medicare regulations, which basically have a Title VI exemption in them, which basically, when Title VI was put in, which basically said that you can't discriminate based on race, Medicare, the private practicing doctors, the AMA at the time, basically objected and said, oh my God, it says, what Title VI says is if you receive any federal funding, you can't discriminate in your care. The AMA and organized medicine at the time basically said, if Johnson wants to pass Medicare, that there has to be a specific exemption in it for the private practice of medicine. Because if a doctor then accepted Medicare payment, they would be unable to discriminate in their office. And so in the Medicare regulations, there's something that says, except for medical practice, except for Medicare. Medicare is exempted from Title VI. So crazy stuff like that. I mean, the racism is baked into the system. It's baked in. If there's any lesson you learn from this, that's what it is. All right, let's quit. I'm tired. Thanks.